Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. My name is Hani El-Mowafi. I'm also a professor of orthopedic surgery in Mansoura University. And I would like firstly to thank Elixir for hosting this workshop. And also I would like also thanks Egyptian Orthopedic Association for hosting was collaborated with Elixir Pharma in this workshop. Today we are speaking our workshop to how to correct the complex food deformities using ILIZAROZ technique. Firstly, I would like to tell the audience that anyone has questions, please can you write your questions, and after I finished from my workshop, I will get the answer, inshallah. And secondly, first I would like to present a small presentation for the principles and also the techniques of ILIZAROZ. And also, I would like to define how the complex foot deformity, as we described as a foot with multiplanar deformities, with or without shortening of the foot. There are many etiological factors affecting the complex foot deformity, like neglected or relapsed club foot, poliomyelitis, pern contracture, neuromuscular diseases, and trauma. Actually, the complex foot deformity, it is formed of combination of bony deformities and joint contracture. And bony deformity usually result as a malorientation of the joint surface and abnormally shaped of the epiphysis. Like here, if we see here, this is an wedge-shaped navicular, and this is maloriented with the pteronavicular as resulting in wedge-shaped head of the talus. Also, it results from joint contracture deformities between bone caused by tightness of joint capsule, ligaments, and musculocutaneous units. Nowadays, ILIZAROZ technique has an important contribution in management of complex foot deformity. So we have to know what is the principle of ILIZAROZ, and also to know what is the technique of ILIZAROZ in treatment or management of complex foot deformity. As we know here, the ILIZAROZ apparatus, it's formed from or the main principle is multiple plans and multiple direction. This is achieved by presence of rings, wire, hinges, plates, thread rods, and also multiple joints or universal joint. ILIZAROZ permit gradual mechanical correction of and deformity in all three orthogonal plans. We have two types of the frames, or one is constrained frame and the other unconstrained. Constrained frame, it means constrained with have a single hinge joint, so it's centered in rotation. It is very important using in the joint in the joint of the ankle joint. So we can use if there is any equinus deformity or something in the ankle joint, we can using constrained frame. But in complex foot deformity, we'll be referring a simple frame of this frame is only affected with one joint, and all axes of during a rotation, axes of the all joints are usually improving around the normal axis of the joint involved. So the frame, it is simply frame using from one joint, and during the correction, all joints will be rotated in the same axial joint. So we have also techniques, we have two techniques of the foot deformity. The first is soft tissue stretching, and the second is osteotomy or bone osteotomy. In soft tissue, it is suitable for children also, as there are some degree of biological plasticity and moldability to the bones of the cartilage, while in adults or older children, bone osteotomy, it is usually suitable for them. In joint or joint and soft tissue distraction, Elizarov methods offer a mechanical efficient method for stretching the joint and soft tissue around this joint. So we have to use all tools or imaging tools for to know how is the orientation of the joints, and we applied this frame, which is a simple frame, which will be applied in the workshop for us. Order of correction, the cases and adduction, if there is uh, talibus equine virus, if there is virus, and also virus of the hind foot must be corrected, and the last one is the hind foot. The rate of distraction, it is usually occurring about 1 centimeter, 1 millimeter per day, and by 0.25 millimeters per 6 hours. Also, it is usually the beginning of distraction is usually you can begin after application of the frame immediately. You can begin distraction. Also, rate is completely, if the rate is completely painless, we have an ability to increase the length of the day. If there is an excessive pain, we have to decrease the rate of distraction. It's strongly recommended that deformity corrected from 5 to 10 degrees centigrade, because there is a tendency for rebound. The foot healed in overcorrected position in about 4 weeks, but preferably for 6 weeks. As usually foot, when you remove the frame, it become swollen. So it is post-operatively, it is better to do an cast, plaster cast for about 1 week, and removable it to allow to take an braces to the foot, and this is brace must be wear all the day. When the swelling the further resolved, custom-made foot, ankle foot orthosis can be made, and the patient must go with the wet cast while waiting to the ankle foot orthosis fabrication. And after 6 months, patient can wear the brace of the foot at night only, the brace at night only. And this is an example for the cases here, and the patient must be corrected 10 and 5 days. And here's the patient. Uh, it's an old patient, and this is the patient after complete correction, which is better to increase the about 5 to 10 degrees. And another example for the patient here, but this patient, we did what's called an adjuvant here, an adjuvant operation, soft tissue operation, for example, which is the same principle of the Bonsetti technique as we did in uh, uh, transfer the extensor hallucis and to the fifth metatarsal, and we have to do an extension to the first thumb, and after that it is where the aim that to unlock the foot, and we begin to correction. And here's the patient after that. Another types, another types of osteotomy, another type of technique is bone osteotomy. We have different methods of osteotomy, like supramural osteotomy and U osteotomy, and also midfoot osteotomy. Some of this osteotomy can correct foot deformity in one plan, such as equinus, calcaneus, valgus, and varus. However, the V osteotomy, there is another type of osteotomy which most option for correction of complex foot deformities, as is usually it affected multiple different plans. And actually, the V osteotomy consists of two limbs, one posterior limb and the other is the anterior limb. The anterior part osteotomy, which may be extended from the middle part of the inferior surface of the calcaneus, extends up to the the neck of talus if there is subtalar arthritis or a subtalar arthrolysis, and ends maybe ends at the end of the calcaneus, superior part of the calcaneus, if the subtalar joint is okay. The posterior part of the osteotomy, it is usually begin from the center or the point center of the superior part and extended to the center of the middle part here, and the osteotomy, if it does not reach it to uh, the neck of talus. So posterior fragment can correct the hind foot, varus, valgus, equinus, and the calcaneus deformity and the lengthening. And the anterior fragment can be corrected equinus, supination, pronation, adducts for the forearm. It is just a small incision, and we can do with a small osteotomy and going to the head of talus and going to the superior part of the calcaneus, and we insert two wires, the first in the anterior part and the second in the posterior part,
بص على
and also it is a good chance to check your osteotomy there. And after you can we have to do and the frame, apply the frame which be mimic to the deformity, as we will see in the workshop, and insert the third wire, which the third wire is going to the tibial component of the surgery. So correction usually started the second post-operative date, as the calcaneus or the foot hasn't an latent period. It is just immediately after immediately
عملت
second
شوية
day,
أهو
because
هعمل
you know
عملت باللي كانوا
the
موجودين.
calcaneus is just purely cancellous bone, and it might be distracted ankle joint healed by distractor while road pulling up to the forefoot.
نعم.
Also, there are
أنا
here
co-host.
the distraction 1 millimeter in the affected side, 1 millimeter per day, and also the other side is we did an in every day we 0.25 millimeter per day with the slower rate. This is what is the aim, because to prevent any collapse, any collapse for the medial ray or lateral ray in the side of correction. And so fixator duration depends on the deformity type. After the correction of the deformity, it was removed after the period equal 1.5 of the period of correction. As the joint distraction, the cast will applied immediately and remove the apparatus. Orthotic was used for long term to maintain the relapsing. This is an example for the patient here, and this is a patient after and before correction with V-osteotomy or ponyosteotomy. Of course, we have many complications like toe flexion contraction like this. So we usually we put an wires in the foot here during the correction, and also pain side infection and osteoporosis to the second part of this session. We are going to workshop and how to apply the Elzaro film in the format foot. And now, thank you. ها تمام، ما فيش مشكلة، ماشي. ماشي، اوكي، مفيش مشاكل. هو احنا بس اوكي. as okay. As we know, as I said, that the frame is consists of two parts. The first is two construct. The first is tibial construct, and the second is foot construct. Tibial construct, it consists of from rings, two rings, and these rings are connected to each other with connecting rods to get stability. And just we are going to now we are going to fix the or to apply the tibial component. Okay, لا لا هات واير، في واير. Okay, so of course we have now the first wire is the reference wire. It is your reference wire, but actually I prefer to okay, so I'm going up to about 5 centimeters from the ankle joint. It is better if sometimes than we have an equinus deformity, so it is becoming more tightness. So we are going up to the ankle about 5 centimeter from the ankle joint. When the first one is the reference wire, which have to be, it must be parallel to the ankle joint. Oh, احنا لازم نحط okay. Okay. After that, we are going as the principle of putting the frame. Yeah. set عندك هامر، هات هامر كده. Okay. And so we're going to type. Okay. And all we know that during we make an tension on the wire in the complete ring, must be tension in 120. اوكي كمل بحركة. اوكي شيل اصف. ماشي. طب مش مشكلة. هات بتاع ده، تمام. اوكي عند. اوكي في واير تاني مش كده؟ طب يبقى احسن. اوكي سو دي ما ينفعش. اوكي اوكي عندك واشر. اوكي سكة. اوكي okay. After fixation of the tibial construct, we have to going to rebuild the foot construct, and we know that we have to make a tension in the other side away from the washering, putting the washer. Okay, and which is very important to when you begin to construct the foot construct. It is must be all tools you must be mimicked the deformity. So the first, and we put here the page, this is the deformity, and this is the line of the calcaneus here. So the wire must be going here perpendicular to the foot, but actually it is must be going that wire must be going as the deformity wire. Okay, امسكها كده. Okay. After that, we are going to fix the wire here. تمام. اوكي، حتى نزل معاه. For tightness, the wire in 5/8 ring, you have to put in make a tension at 90, not like the ring 120, but you have to do tension about 90.
External fixation. You have very good alignment. So if you are satisfied with this X-ray, have a look. This is after 16 or 17 days. Massively positive.
Okay. Fire thing. Better to fix. Okay. Right. Right. Okay. Okay. The one in the calcaneus and the other in the forefoot. Okay, of course we must go going from the big to, but sorry about that. But okay, we did an wire in metatarsal here. Okay. Okay. If we see that if it is small, ما عندكش اختبار. Okay. If it's small, so we can do an extension with plate here. and here we are going to get fix. Okay. نعم من تحت من تحت. طب خلاص حطها من فوق. اوكي. ثانية. اوكي. هي ثابتة. تايتن ولا ده وده اسم تايتن اللي فوق الأول، على اللي فوق الأول. اوكي. اوكي. تايتن اوكي مفيش مشكلة. So we have here no هات لي بقى مفيش مشاكل دي، مفيش مشكلة. لا مفيش عندك بوستات كبيرة، مفيش غير كده. ايه 3. طب ما ده كويس، هاته. هات لي الرود بقى. ما عندكش رود طويل؟ خرج لي بره. Okay, this is the middle side, and this is the for distraction, for just distraction about 0.25 millimeter per day, and so we are going to lateral one, which is important here. يا حبيبي روز ما عندكش بتاع ده بوستات؟ هات لي، هات 3 و2. يا يبقى ده هنا. طب ثانية واحدة، مش هتيجي ده. يا اوكي، استنى، هات بليت عادي، هات بليت عادي. في اتنين بليت، اتنين. حط بقى. يبقى خليها احسن هنا عشان ترفع لنا التنشن. اوكي. مثلا ممكن يجيبه خلاص. اوكي، ده اصل حاجة عندي. طب عملنا. اوكي. اوكي. اقفل هنا. Okay, and now we have two constructs. The first one is the tibial construct, which is the guide to correct the foot, and this is the foot construct, and this is the construct. It is usually mimics the deformity as we see here. The deformity more lateral, so we have distracted with this rod. We distracted it this rod, and here distracted 1 millimeter or more. If there is joint distraction, more we can increasing more than 1 millimeter per day. And but it is very important here to do the other side, or the large side, to do in every day is about 0.25 millimeters to prevent any collapse for all joint there. So we have to connect it both with each other. But actually, this is I said that we have two types of frame. One is the constant and unconstant. This is the apparatus is unconstant, so it allows the joint to by correction. It allows each joint going to each going to the or corrected immediately. So we did what is called here. This is the main side of the deformity. So we it's better. We are going to heal at this side medially here, fix with the universal joint here. Uh, Okay. So مسمار كبير. Okay. So for foot construct, it can correct the abduction of the forefoot. But if we have here, as we said, this is an valgus hind foot, so we make an this is joint, and so we did a distraction in the posterolateral or posterolateral aspect here to correct the valgus. And now another road here. ده انا مش عاوز جوينت. اوكي طب حط لي طلع لي واحد من هنا بليت. هات هات لي بليت تاني. اوكي ده لا عادي بس التلاتة ولا ماشي. اوكي اوكي. So now another one. Okay. See? Okay. So this road uh, is allows the frame to be mimics the deformity, and this is the road for the hind foot, but it must be a little bit posterior here, and to correct the hind foot and hind foot valgus or varus or something like that. And this is the road for distraction here, and both roads here for distraction of the midfoot correction and If we'd like to, after that, we said that the Aquinas, it is usually occur later, but actually we can going to using another here for Aquinas. عاوز اوكي مفيش مشاكل هات كده اوكي مش بس اكتر من كده فيه 3 امسك مم. ما عندكش بتاع بص اهو مفيش اكتر من كده طب ماشي امسك كده امسك ثانية واحدة خلاص ماشي امسك كده امسك تبقى بعيدة and from here after correction the foot and you can last step is for the Aquinas we can correct it here with we can do compression from by this also there is an what is called Teflon nuts it's better to using more Teflon nuts for this for construct of the frame of the foot and this is that's all and another for how to apply the frame and this is a frame for joint distraction only with technique which is very useful there. Thank you very much. Any questions? Okay. Could it be used in treatment of adult flexible flat foot? Okay. Actually, I like, of course, ILIZAROZ, but adult flexible flat foot is better to treat operatively, as there are many etiology is maybe stage 1 or stage 2, stage 3, but actually it is better to do open surgery. It does not need a frame. Also, I think the frame and ILIZAROZ frame, it is important to use in a special situation like many operation before skin, poor skin, like mini operation prior your operation, and it's the first. And the second, it is we consider this as a last uh, it is the last options for the patient to correct the foot. But adult flexible flat foot, I think it's better to do an open surgery, and as a types of or staging of the disease. Another questions? Okay. Thank you very much. And again, I would like to thank Elixir Pharma for hosting this workshop. Thank you so much. And also, I would like to thank Egyptian Orthopedic Association for hosting this workshop. Thank you very much.